Welcome, everybody. This is January 14th, 2021, Rush University Medical Center Division of Nephrology Renal Biopsy Conference. We've got a great case today. Our CME activity code is 481292. As usual, the patient's been de-identified. We don't have any disclosures. It will be recorded. We ask everybody to join our YouTube channel. We post these about a week later on YouTube, and we appreciate everyone joining. That's about it. Let's get started. I think Dr. Zhang is going to read the case.
Yep. So the patient is a 60-year-old Black man with a past medical history of idiopathic transverse myelitis, bilateral trochanteric pressure ulcers with osteomyelitis, who was referred for acute kidney injury. The patient initially presented for a planned wound debridement of trochanteric ulcers and suspected chronic osteomyelitis. His serum creatinine 2 months prior to admission was between 0.6 to 0.7. His UAs prior to admission had traced to negative protein on dipstick and negative blood on dipstick. On admission, his serum creatinine was 1 milligrams per deciliter. He underwent his planned surgery, and on post-op day 2, his serum creatinine increased to 1.38 milligrams per deciliter. His blood pressure was recorded as stable throughout his entire procedure. His initial UA was significant for 1+ protein, trace blood, 500 leukocyte esterases, 35 WBCs with few bacteria. His urine culture was significant for greater than 100,000 CFUs per mils of Pseudomonas. His wound culture grew Pseudomonas and MRSA. His bone biopsy grew coag-negative staph. Denied any use of NSAIDs or over-the-counter medications or supplements for any illicit drug use prior to admission. His serum creatinine increased to 6.2 milligrams per deciliter 1 week after his surgery. He remained non-oliguric. On review of systems, he has chronic lower extremity weaknesses and muscle spasms, but otherwise his 12-point review of systems were negative. For past medical history, he has the idiopathic transverse myelitis, decubitus ulcers of bilateral trochanter, and osteomyelitis. For his social history, he has no smoking history, no current alcohol use, and he denied any history of illicit drug use. For his family history, he has no family history of kidney disease, and he has no known allergies. His medications prior to admission includes Tylenol, PRN for pain, Zofran, PRN for nausea, famotidine 20 milligrams daily, tramadol 50 milligrams as needed, melatonin 5 milligrams nightly, a multivitamin, a hydralazine 10 milligrams PRN for blood pressure, and he was on dronabinol oil. For his medications during admission, prior to us being consulted, he got cefazolin ×1 perioperatively. He got fentanyl, propofol, and lidocaine during his surgery. He was started on fluconazole on postoperative day 1 and Augmentin postoperative day 2.
Roger, you want to tell them what drobaninol oil is?
It's marijuana oil.
Okay.
On physical exam, his blood pressure was 122/85, heart rate was 89. He was afebrile. His respiratory was 18, saturating 99% on room air. His weight was 77 kilograms with a BMI of 25. He was awake, alert, in no acute distress. His mucous membranes were moist without lesions. He had no adenopathy. He had no increased work of breathing. His lungs were clear to auscultation bilaterally. His heart was regular in rate and rhythm. He had a wound back over his left trochanter, and he has a chronic right trochanteric ulcer as well. He had chronic weaknesses of his bilateral lower extremities. He had no lower extremity edema. There were no rashes that were visible. For his labs, prior to biopsy, his sodium was 136, potassium 4, chloride 103, bicarb of 21, a BUN of 61, and serum creatinine of 6.06, glucose of 88, total protein 5.9, albumin of 2, with normal LFTs. His CBC, he had a white count of 9.44 with a normal differential. His hemoglobin was 7.2. His hematocrit was 22.8 with a platelet of 374. For his immunological workup, his ANA was negative, anti-double-stranded DNA was negative, ANCA, anti-GBM were both negative. C3 was normal at 112. C4 was slightly low at 9.6. His UPEP and SPEP were negative for paraproteins. For his UA, his initial UA had a specific gravity of 1.007, pH of 7, 1 plus protein, trace blood, 500 leukocyte esterases, 35 WBC, 2 RBC with few bacteria. He had a repeat UA, except this time with a Foley catheter that was inserted 2 hours prior to getting the UA. He had a specific gravity of 1.009, pH of 7, 2 plus protein, 2 plus blood, 500 leukocyte esterases, greater than 182 WBCs, 107 RBCs, many bacteria. His UPC was 2.7 grams per gram with a UAC of 0.9 grams per gram. In terms of infectious workup, his urine culture was positive for greater than 100 colony-forming units per mil of Pseudomonas, wound culture with MRSA, bone culture with coag-negative staph. Hep B surface antigen, HCV antibody, and COVID were both negative. For his retroperitoneal ultrasound, it was read as normal in size and echogenicity of both kidneys. Patient underwent a renal biopsy.
Great. So everyone else is muted except the faculty, but if you have any questions, just put it in the chat board and we'll try to answer it as we go along. Are there any questions for the case for Dr. Zhang?
Yeah, I assume there's no eosinophilia. The differential was normal, so I know it's kind of.
There was no eosinophilia on his differential.
Is there a reason they didn't treat the Pseudomonas?
I think a couple of days after he got biopsied, where we got on, he was started on Levaquin.
Does that give the answer to the biopsy?
Depends on the timing. How you interpret the timing.
Does he have a chronic Foley, or he just had the Foley inserted once he came in?
Yeah, he did not have a Foley when he probably had a Foley during surgery, but then when we evaluated him, he initially did not have a Foley. And then he had a Foley inserted a few days after.
Can we just, let's go to the next slide. And this basically shows the course where he had surgery and his linear rise in serum creatinine, and at the time of the renal biopsy, fairly linear, non-oliguric the whole time. Dr. Corbett, why don't you walk us through this case?
Yeah, you know what? One other question. Do we know what his blood pressures did intraoperatively?
It was reported as stable throughout the entire procedure.
Okay.
It was not hypotensive.
So we have a gentleman who has a history of chronic osteo with otherwise normal renal function of the creatinine of 0.7 and urinalysis that's really not that remarkable, at least as baseline. And then all of a sudden comes in to get this procedure done. And post-operatively, his creatinine rises precipitously, as we just saw. He's non-oliguric. And his urinalysis is still remarkable for some protein, but most remarkable for pyuria and leukocyte esterase, which may be because of urinary tract infection, maybe something else. And he's got some, trace blood with only 2 red cells. I mean, there's a lot of potential issues here, and then the serologic workup, with the exception of a low C4, is other words pretty much unremarkable. And as I was reading this, I mean, first I was thinking, has this guy got some sort of secondary amyloid due to chronic osteomyelitis? But and you can have interstitial amyloid, which doesn't give you a lot of proteinuria, but can give you a progressive renal disease as well as glomerular amyloid. But you'd expected him to have more proteinuria, and I would have thought a higher creatinine right from the get-go. This all seems to occur perioperatively. Acute tubular necrosis from some relative drop in blood pressure that may not have gotten caught. It would be one consideration, but again, then you have to resolve the fact that he's got almost 3 grams of protein in the urine with an elevated urine albumin creatinine ratio as well. With all the pyuria, you kind of can wonder about an acute interstitial nephritis, but it doesn't sound like he'd been on antibiotics prior to coming in. It's kind of a question, actually. I think someone else had posed that in the chat. Roger Zhang, had this guy been on anything as far as antibiotics prior?
It was not part of his home meds, and he wasn't on antibiotics before.
So it kind of makes it a little hard to attribute this to acute interstitial nephritis because he really had just gotten placed on things. So then for me, at least, it comes back now to, is this guy got some sort of infection-related glomerulonephritis? And that's kind of where I think this, I mean, personally, that's where I'm going to, it gives you, you get proteinuria, you can have pyuria, you would expect there'd be a few more red cells. What else? He's got this osteomyelitis, and he's got, he's got MRSA as well as Staph, or he's got quite negative Staph as well. He's got everything growing out. And you don't have to have a low C3 all the time. I mean, you can have a low C4 occasionally, but in the complements can occasionally be normal. So I don't know, for me, I'm starting to wonder whether he's got some sort of a proliferative glomerulonephritis due to his infection, and it just, for whatever reason, became evident post-operatively. I know, boy, you look at this course and the thing that would, the easiest answer for me is this guy has ATN, but then I can't reconcile all the other things that are going on. So I'm going to, take a stab at the fact that this guy, for whatever reason, it became apparent that post-operatively, this guy has some sort of a proliferative glomerulonephritis, which may or may not be IgA positive, which would otherwise be termed an infection-related glomerulonephritis.
Great. Sam, you want to tell us your thoughts on this case?
So what I was saying is that Steve comments of being an infection-associated GN, obviously somebody coming in with chronic osteomyelitis, is a possibility. Maybe they stirred the pot a little bit when they operated on him, so now he's really having more of an acute infection-associated glomerulonephritis from IgA. Now, if we didn't have the active urine sediment, so I think that's really high up on the differential. If we didn't have the active urine sediment and we get consulted on all these post-op cases all the time, we just say he has ATN. You went to surgery, even there isn't documented hypotension. Your surgeon can have normotensive ATN just from vasoconstriction, other things that happen during the time of surgery. But that wouldn't explain the active urine. On the other hand, interstitial nephritis from some of the antibiotics enter into the differential. The problem there is that you wouldn't expect him to go into acute renal failure immediately right after surgery. But two things could have happened. I mean, his initial course could have been ATN. Then later on in his course, he could have developed a kind of allergic interstitial nephritis from one of the beta-lactamase antibiotics that he received. The other thing that I wanted to raise is, could he have Cas nephropathy? So if you look at the protein to creatinine ratio, it's a little higher than what you'd expect from the albumin to creatinine ratio. So in some of these patients who develop Cas nephropathy, they may have light chains in the urine and do fine, and then all of a sudden some acute event happens like surgery or NSAID or fever or whatever, and then they develop acute Cas nephropathy. So the timing of that would be something we would consider. So just kind of review. So either an IgA-associated, infection-associated GN, ATN, and then interstitial nephritis. And then I guess last was just something we think about, Cas nephropathy that was precipitated by the surgery. My previous comment about the levaquin, if this was somebody who had a solitary kidney, then pyelonephritis from the Pseudomonas infection would also be something we'd consider. But to have bilateral pyelonephritis would be something unusual, but I guess it's still possible.
So what about the famotidine?
Famotidine by itself, I guess you can have, usually we see with PPIs more than with the H2 receptor blockers, but I guess it's possible.
And hydralazine?
Well, hydralazine, you'd expect more of a vasculitic lesion. And then he wasn't put on the hydralazine. He wasn't on it before. Oh, he was on hydralazine before? Or?
Small dose PRN.
Then the timing, like, why now? We occasionally get burned by these why now things, but it isn't really kind of a new medication. And he really doesn't have much nephritis. He doesn't really have that much hematuria. So I think that would be a little bit less likely. I think we'd see, you know, ANA being positive. It was a hydralazine-associated, you know, vasculitis, typically positive. So I think the hydralazine would be less likely just from the timing and the clinical presentation.
It also seems to be associated with the really high doses. It's somewhat dose dependent, high doses for longer times, and 10 PRN is a pretty small dose. But so we saw we you know, we had this case, and you know, we watched the creatinine climb, as I showed, you know, in the graph every day, and every day we kept thinking this is, you know, this is ATN, and we didn't, you know, normotensive ATN, if you want to call it that, is not an uncommon diagnosis, and certainly post-surgery. It wasn't a big surgery, but we see it a lot. And it kept climbing and climbing, and Dr. Zhang finally looked at me, and we kind of said, do we need to biopsy this guy? And basically what I told him, and I'm not going to give anything away here one way or the other, but I said, well, you know, it's probably ATN, but you got to biopsy people. And if you don't biopsy an ATN once in a while, you're not doing enough biopsies. That's what I always try to teach the fellows. So, and again, I'm not saying what it is or isn't, but that was our running diagnosis here, was that it was ATN. But we finally figured, well, you know, let's just take a look here and see what's going on. Bill, anybody else have any other points to make on this?
No, I think that covered the differential very well.
All right, then we're going to go directly to the wheel and see who reads this case. All right. Ah, 2 weeks in a row, the wheel picks Faraz. Faraz, are you here today?
Okay, so sorry about that. We've got a trichrome at low power. Looks like we've got 2 cores. The main one is up at the top. There's you know, densely packed tubules. I see a few glomeruli. Can't really comment on it at this power. And there's not much blue staining material. I would say maybe 5 to 10% fibrosis. 10 to 15.
Yeah, the thing is for us, circle some normal tubules.
So like over here a little bit.
Let's see. You're, I would say over like around
Up top also.
So those tubules are not. Yeah, I see. Are you moving the pointer around?
Yeah, I think so.
Yeah, it's just sitting there in the top right.
How about now at the bottom? I'm close to like 7 o'clock-ish.
Yeah.
Further down the
over around, yeah. I don't see the arrow moving, but around 7 o'clock, there's some normal tubules. And the rest of the core, there's really not tightly packed, back-to-back looking tubules. Well, and then there's a hint of what's going on in the bottom core. Do you see that area? How would you describe it?
There looks like, you know, a little closer to the right edge. There's an infiltrate. It looks like really cellular.
That's right.
It doesn't look normal, that area.
Yeah, a dense cellular infiltrate. I agree. I think on the next slide will help clarify, because sometimes the trichrome could be misleading when there's some edema.
Okay, so we've got low power H&E. Yeah, this is more evident. The tubules are actually pretty spaced out. There's a lot of cellular infiltrate. There's a glomerulus here and one up here. It's hard to comment on them at this power, but the tubules definitely are not closely packed together.
Yeah. There's a lot of interstitial edema, spacing them apart, and diffuse, dense cellular infiltrates, as you pointed out. Good.
And then higher power H&E. Medium power H&E. Yeah, this looks like all interstitium. I don't see a glomerulus. It's all interstitial infiltrate. it's at this power, it would be really hard to tell if there are any neutrophils, but looks like mostly lymphocytic.
Okay, yeah, and then how about intensity? Would you say this is mild, moderate?
Severe, probably.
Yeah, this is severe intensity. I mean, you have areas where it's almost sheets of inflammatory cells. Yeah.
And then this is again medium power H&E. We've got a couple glomeruli, 2.5. This one at the bottom looks normal in size. There's plenty of open loops. There may be some mesangial expansion.
Would probably be easier to see at a higher power on another stage. But overall, the glomeruli look unaffected, and you can see how this is really a tubulo-interstitial process, sparing the glomeruli.
Okay. Yeah. Yeah. You still have a lot of interstitial edema and spaced out tubules.
Yeah. Do you see anything that looks like a granuloma?
Yeah, could this be?
No, that's a tubule. The answer should have been no.
Okay.
Yeah. I don't know what that pink blob is. Pink blob.
Gotcha. Okay, so this is higher power H&E, high power H&E. I think this is a neutrophil right here in the middle.
Yes. Yeah. Yeah. Where is that?
Is that in I think this is a tubule here.
Yeah. Yeah. So there's
that in a tubule.
Yeah. There's a marked tubulitis. All these cells are attacking the tubules.
Mm-hmm.
On the PAS stain, where we get a clear indication of the tubular basement membrane, they'll all be crossing over. Yeah. So very active tubulitis.
Okay.
Yeah. So yeah. So what now that we're at a higher power, what are most of these cells?
Most of them look like lymphocytes.
Yeah. Yeah.
Are there maybe a couple?
And then there's an occasional neutrophil. There's an occasional eosinophil if you go back to where you were at.
Like here?
Yeah. Yeah, so there's a couple eosinophil, and then at higher power, there's a few plasma cells we'll be able to see also.
Okay.
Okay. All right. Yeah. Let's have next slide.
So this is high power PAS. You can see like the basement membranes don't stain as darkly. There's a lot of cellular infiltrate. There's loss of brush border in the tubules. So you have some ATN going on.
And yeah, look at those other surrounding tubules. Look at the larger nuclei are the tubular nuclei. And so all the smaller cells are lymphocytes.
Okay.
If this was a transplant, this would be a severe cellular rejection.
Oh, okay.
Very active tubulitis, tubulo-interstitial nephritis.
Is this a mitotic figure?
Yeah, it looks like one. So yeah, so there's some tubular epithelium's getting damaged and is attempting to regenerate.
David, would you say this looks like rejection?
Oh no, I said if this was a transplant.
No, that's what I mean. If it was is this basically with tubulitis and lymphocytic infiltrate, it's basically like rejection.
Yeah. Okay,
so this is high power H&E. Yeah, you can see a lot of eosinophils in this field.
Mm-hmm.
And we've got tubule here, mm-hmm. And is that like a lymphocyte in the tubule?
Yep. And then go over to 3 o'clock. There's a cell with a lot of cytoplasm. Yeah, there you go. Do you know what that one is?
Is that That's not a plasma cell, is it?
It is, yeah. It's on
Oh,
the,
it
yeah.
is. Okay.
Mario had said in the chat, look at the plasma cell.
Okay.
Now, this one has a lot more eosinophils in it, right?
Yeah.
I mean, it's packed with them.
Yeah. So it did have some plasma cells. So it didn't have a storiform appearance like IgG4, but to rule that out, I did do the stain and it was negative for IgG4 disease. Okay, how about next slide?
Okay. Again, high power H&E, lots of eosinophils. This looks up here, looks like a tubule that's sloughing off, and you have some ATN. What else? Again, a lot of interstitial edema, infiltrate.
Yeah, and a lot of degranulating eosinophils. Yeah.
David, is this in the middle of there? Is that degrading eosinophils, or is it protein reabsorption?
Well, the little red dots scattered in
Yeah.
the interstitium, yeah, without a nucleus, yeah, those are degranulating eosinophils.
Okay.
Yeah.
High power PAS. We've got one glomerulus. It looks normal in size, has a good amount of open loops. There seems to be some mesangial expansion, and some of the capillary loops look a little thicker. And then outside of that, maybe there are a couple areas of like hypercellularity, like here.
I mean, it looks pretty close to a normal looking glomerulus to me.
Okay.
You know, the mesangial areas have 2 nuclei in them. Yeah, the mesangium's not markedly expanded. It looks pretty spared from inflammation.
Okay. And then
for us, do you
Yeah.
remember what I know this is early in your path education, but do you remember what the glomerular lesion that would one of the predominant glomerular lesions of a post-infectious or infection-related GN?
I do not.
Well, it's polys, and you can see a lot of, you typically see a lot of polys, and that's very, very common in post-strep, but we also can see it in some of the others. The remarkable thing is there's not a single poly sticking out here.
Okay. And then again, outside in the interstitium, you have a lot of infiltrate and edema separating the tubules. There's, sloughing of the brush borders and thinning of the epithelium. So there's some ATN going on.
Yep, good.
Is this a cast here up at the top left?
Highland cast, yeah,
Highland cast.
protein.
Okay.
Okay, yeah, next slide.
The question of paraproteinemia did come up, and we don't really see the cast signs associated with it. We had one cast there and it wasn't fractured. Not that completely rules it out, but maybe worth mentioning.
And then we've got high power H&E. We've got a glomerulus. This one looks pretty similar to the other ones we've seen so far. Lots of open loops. It's not hypercellular. Not really expanded mesangium. And then outside of that, in the interstitium, again, a lot more of the same interstitial infiltrate.
Yeah, it shows how diffuse the process is. We don't have a single image without any interstitial nephritis on it.
And then we've got high power Jones stain. There's no breaks in the basement membrane.
Look up at 12 o'clock, Faraz. Yeah.
Up here?
Yeah.
Are these like holes?
Yeah.
Okay.
Yeah, you have some areas that hold, and if you go straight down, keep going down. Yeah, keep going down. One more loop. Yeah, look at that.
Oh, that's a hole.
Yeah.
Okay. And there's another one next to it.
Yeah.
Is this one also over
Yeah,
here?
yeah, more holes
Okay.
there. And then there's some subtle spikes as well, like back up at 12
Let's
o'clock.
see.
I mean,
Yeah, keep going up.
Is it
Yeah, you can see
here?
how that's not, yeah, it's not smooth.
Yeah.
With contour.
Okay.
It was, yeah, so holes and spikes, what's that suggestive of?
Makes you think of something you know, like membranous.
Yes, yeah.
And then immunofluorescence, we've got IgG. It looks like it's positive in the capillary walls and weakly positive in the mesangium.
In membranous, it's hard to say when it's truly positive in mesangium, because you know the GBM goes over the mesangium and the perimesangial area, and it kind of mimics that there's mesangial staining.
Okay.
But definitely diffuse capillary wall staining.
Yeah, and it looks granular. It's not linear.
Yeah.
Okay. And then EM, we've got blood space here in the middle. We've got the membrane here, and you have a lot of intramembranous deposits.
Yeah. How about the foot processes?
Are they effaced over up at the top here?
Yeah. Yeah, overall, there's some preservation where there are no deposits if you go down on the other side of the loop.
Yeah, on this side here.
Yeah, you can see, yeah, they're preserved there, but otherwise diffusely effaced.
Okay.
And then at the other loop, down at the bottom left of the screen.
Oh, over here.
Yeah, there. It looks like there's probably some deposits that have been resorbed, and there's kind of irregular thickening of the GBM with areas of lucency.
Yeah.
Yeah, there's probably some old deposits there that are now resorbed.
Gotcha. Okay.
Yeah.
And again with EM, this is the blood space. We're in the capillary lumen, and then you've got deposits on from like 8 to 9 o'clock here, and then some deposits here from like 4 to 5 o'clock, and then here these look like the lucency areas where there's possibly some resorption, like you described in the last slide.
Yep.
Okay. And then yeah, the foot processes look pretty effaced down at the bottom here, and probably up here too.
Yeah, good.
I'm glad to see that everybody put this at the top of their differential. No surprises here. My gosh.
And then higher power EM, and you really see the deposits much closer up. And is it the basement membrane that's like expanding around them that causes the spikes?
Well, yeah. Well, so these are intramembranous deposit, because you now see basement membrane completely surrounding them.
Mm-hmm.
If it was an earlier stage, there would be a spike, but these are pretty much diffusely intramembranous.
Okay, and then yeah, here's some reabsorption.
Yeah.
And the foot processes look effaced here too.
Yeah. All right. So what's your diagnosis?
Okay, so we've got a few different things. We've got membranous nephropathy. We've got ATN and really bad interstitial nephritis.
Yeah.
Good. So,
Could I ask a question before you discuss it? Was there an ACE level?
there was not.
And then one other thing I think of when I see spikes is we think of amyloid as well as membranous. That wouldn't give you holes, but since amyloid was in the differential, it's just something to bring up.
Congo red was negative. It was done. Dr. Corbett, you want to try to put this all together for us?
So as I said, no problem. I'll discuss this. Not piece of cake. David, did you do the PLA2R already?
Yes, it was negative.
Negative. So, I mean, this obviously there's a lot of moving parts to this. I mean, with the PLA2R being negative and this background and this membranous, and you got to think about secondary causes of membranous. I mean, we've already ruled out lupus. At least the ANA is negative, and there's nothing else to go along with lupus. Paraproteins associated with membranous. So this wasn't a monoclonal antibody, right? It wasn't an IgG kappa or anything. David?
No, interestingly, the lambda had slightly stronger staining than the kappa. The lambda I was grade is like 3+, and the kappa was 2 to 3+, the lambda 1+. So I did raise the possibility that paraprotein should be excluded.
So, I mean, that is one thing we can see met with membranous. Occasionally it's with MPGN. It's more often we talk about it with MPGN, but it can be seen with membranous as well. So paraprotein associated membranous. Bill brought up an interesting point, with the interstitial nephritis, which we'll get into as well. Sarcoid would be a possibility. I mean, people with sarcoid can occasionally have membranous. So an ACE level would be something worth pursuing.
Steve, apparently we did get it. Dr. Zhang just informed me, and it was normal. I'd forgotten.
Whose case was this?
Keep going.
Well, you gotta have that good-natured give and take a little bit here. The price of being in charge. So the ACE was negative, so that makes it less likely. Then my favorite is, I guess we've already got hepatitis B and C and those things, so the membranous associated with those would obviously have been kind of taken care of. Then my favorite is still someone in his age group, an occult malignancy has to be at least a consideration. The interstitial nephritis, to put the two of them together, like I say, something like sarcoid would be one way to do it. NSAIDs, people talk about NSAIDs causing membranous. I have to admit it seems to be something, in my opinion, is talked about a lot more than it's actually seen. And usually the interstitial nephritis with NSAIDs isn't an eosinophilic type of interstitial nephritis. It's more often a lymphocytic. And Roger kind of pointed this out as he was asking people to discuss early on. This whole thing with famotidine, which is what, Pepsid? For years, we talked about Tagamet as being associated. Cimetidine would be associated with acute interstitial nephritis. For whatever reason, for some reason, Pepsid or famotidine is kind of less often referred to as being associated with it, but I don't know why it couldn't be. So I guess it's a possibility. I think the really interesting thing is, why would it all of a sudden become apparent now? Because, for sure, I think the acute renal failure is acute interstitial nephritis here as much as anything. I mean, the glomeruli, as Roger pointed out, as Faraz pointed out, the glomeruli look pretty doggone good. There's no evidence of an infection-related GN here to account for it. So the interstitial nephritis and ATN associated with it seems to be what the predominant issue for his acute kidney injury is. I don't know what it's from. It could be from one of these other antibiotics, but I would think, granted, he'd been on them for about a week by the time he got biopsied, it would seem, because you followed him for a while. But it is interesting that we usually talk about things like penicillins and sulfas, et cetera, as taking usually a week or two before you start to see the interstitial nephritis. So I guess it still is a possibility. Again, the membranous...
You look at his AKI, and it started immediately post-op.
No, that's right.
And that was day one of cephalosporin.
No, that's why the ATN, at least in part, may have been the ATN was what we saw. It was what was causing this acutely. It also, there's no question. It all his AKI starts right after the surgery, so it makes it even harder to reconcile how the interstitial nephritis could be doing that, unless for whatever reason it just became apparent. I don't have a good answer, but for sure the interstitial nephritis was fairly impressive. And so, that's kind of my way of working around, what's going on. I still think, like I say, you need to do a workup for a malignancy here, given this guy's age and the fact that he has membranous that's PLA2R negative. And we'll get into the issue, I guess later, if it's worth getting into of the possibility of having a malignancy in somebody that's PLA2R positive. But the fact that he's negative, I think, makes looking for secondary causes far more high up on your list. What to do? Stop whatever drug you think may be causing this, such as his antibiotics, or switch them around if you can. Stop the famotidine if it hasn't already been done. And then the issue of steroids. And as long as his infectious disease feels like he can be covered for his infection, then I think you need to put this guy on steroids to help accelerate his improvement, because it's been shown that the longer you go with someone like this without treating them, the less likely they're going to get back to their baseline. The issue of how to treat the membranous, I think, gets back to what's causing it. So I'll end there unless there's a specific thing I haven't covered or something more you want me to say.
No, there's a lot of issues I'm sorry, Bill.
Oh, no, I'm sorry. I was just going to say that I also think the sarcoid membranous cases were most often PLA2R positive, if I remember from the literature, but I'd have to double check on that. And you wonder if there's thrombospondin or if there's one of the NEL ones that are associated with malignancy. There's other exostosin, there's other antigens we're finding every day. I don't think that we're testing for them right now at Rush, but it might be worth getting it tested for, depending on, how in depth we want to look for the cause of the membranous.
Casey, how do you put this together?
It's tough to have a unifying diagnosis that explains all three findings of the AIN, the ATN, and the membranous. I do believe, based on the histologic appearance of the deposits, that the membranous has been going on for a while, and I'm not really sure if it has anything to do with what he's in the hospital for right now. That could have been something that's just been smoldering in the background. And
well, I'm glad you brought that up, because I think that's a really important point. And if you remember, he had a normal urinalysis 2 months ago.
Yeah. I've we've seen a couple of cases where, we find membranous just kind of serendipitously without really having a lot of urinary abnormalities. It's just there in the background. We do the biopsy for some other reason, not really proteinuria. We do it for AKI, and it's there, and we're not really sure what it's from and what to do about it. But clearly, it's not the cause of the AKI. I mean, some of those deposits were already had a GBM made over it. So these are old, weeks to maybe months old. So the current infection could be responsible for the interstitial nephritis. I know that usually, eosinophils go along with the medication induced, but I do think that he probably had both the membranous and interstitial nephritis, and I think that the surgical aspect of this probably just a little bit of ATN. Just he had such a little reserve from the AIN that his creatinine just took off, and that forced us into biopsying him. So hopefully his ATM will resolve, but I do believe that he deserves to get a course of steroids and some switching of the antibiotics for his AIN. It's unfortunate because it looks like David said at the beginning, a lot of his tubules were gone. And truthfully, even as bad as the AIN looks, I've had AINs with really high creatinines, and I expect the creatinine not to really improve that much. I say, oh, it's creatinine 6. I give them steroids, maybe it'll come down to 3 or 4, and 6 months later they're at like 1.5. So you'll be amazed, because AIN could be patchy. So, maybe you're in a bad area and you treat it, and maybe you have some better areas in the kidney, and your creatinine will recover. So I wouldn't withhold steroid therapy just because of how extensive the ATN was, or how significant the scarring or the interstitial fibrosis may have been on the biopsy. But I don't have anything that puts all three of them together.
Casey, what dose of steroids do you use?
I use 60 milligrams of prednisone daily. I just go full force. There's really, people are all over the place. You could do 40, you could do 60. I don't think there's that much of a difference. I think anything above 20 to 30 should probably work. But I've just been trained to use 60. I've never really tried anything less, but there's not a lot of good data on how much steroid to use. But what is important is, if you use it early on, within the first 2 weeks of diagnosis, the prognosis tends to be a lot better. And overall, those who get steroids have a better prognosis than those who don't. So I think early is better, but 40 versus 60, I'm not sure if there's a big difference.
I think it's nice that you said that, because if I were to give 40 and then later they don't get better, I would always question myself, should I have given 60? And so you don't want to have that question later on if it is a non-responder.
So next slide. So we indeed did give steroids. I did something I'd never done before. I pulsed him. I gave him 250 milligrams of solumedrol, and there's zero evidence for doing anything like that. But this was the worst interstitial nephritis I'd ever seen, and it's the probably the most rapid rising in creatinine I've ever seen since our running diagnosis was ATN. So we gave him 250 milligrams of solumedrol IV for 3 days, and then just put him on prednisone. Who knows if that makes a difference? Who knows what any of these doses really are different? But I felt pretty strongly that he needed a higher dose than less, and I just went rogue and gave him high dose IV solumedrol. Here you can see where we gave the steroids. His creatinine peaked off a couple days later. Actually, he started making even more urine and came down. He was discharged here to a rehab institute. And so as of now, he's being followed by another nephrologist. We're trying to get some follow-up. We sent him home on steroids with a taper schedule, and hopefully we'll have a little more follow-up shortly. We don't really know what caused this. Nothing fits, as Dr. Corbett said. The timing doesn't fit anything. And maybe Sam's right. Maybe Dr. Salzberg's right. He had post-op ATN from a very mild, stable operation, and then developed some interstitial nephritis later. But that, I mean, this is that's a pretty rip-roaring interstitial nephritis. I think that's kind of, it may even be he had an element when he came in, because he had pyuria all along. Foley or no Foley, he had a lot of pyuria. So we're treating him for interstitial nephritis, and I think that's the AKI part of the case. But I want to talk about this membranous a little bit, because this is really the interesting lesion that I don't know how you can have this lesion and 2 months earlier not have proteinuria. But if you look at this, if you look at this biopsy, you can pretty much see these are all intramembranous deposits. Dr. Corbett alluded to, he went over the etiologies. It's a long list. You can find 20 different lists. It really doesn't matter. Some of these are strong and some of these aren't. Malignancy, even this is up to date. It said may not be causative even. There's still some question in some people's minds. Certainly, we see a lot of lupus membranous and other autoimmune diseases like mixed connective tissue disease. The most common lesion is membranous. Non-steroidals, I agree with Dr. Corbett. I'm not so sure there's an association there. A lot of people take non-steroidals, but these other drugs are well established. Thyroiditis, sarcoid, Billment, Dr. Whittier mentioned. And GVHD, we've seen membranous from that. The two that aren't on here, I would say for the fellows that could hit your boards are sometimes IgG4 related disease will have a membranous associated with it. And sometimes antiphospholipid antibody syndrome will have a membranous associated with it. So there's something maybe to remember. So the story goes way back, but I've never found a better picture of this. But it's relevant because we talked about the pathophysiology of membranous for years before we actually knew what was going on. But the idea is that here's this normal glomerular based membrane, fenestrated endothelium, basement membrane, and epithelial cells, and you have antibodies that you've got these antigens that are in the podocytes that either become and released and become antigenic, or we're not sure exactly what triggers what. But in any event, you develop an antibody against one of a number of antigens, and we're going to go over these a little bit. And the antibody then crosses and forms these large epithelial deposits, which we see. And for the longest time, this was just theory. We didn't really know that much about it. There were some animal models with Hayman nephritis, but we really didn't quite understand what was going on until was 2009 when Beck and Salant reported in the New England Journal of Medicine the first antigen that was clearly correlated with membranous, and it was the PLA2R antigen, and the antibody circulating in the blood. So they had all of Koch's postulates, if you will, showing that this is pathogenic. The antibody's in the blood, combines with the antigen and forms these deposits, and the levels seem to go up with disease, go down with disease, et cetera. It's a really, really good marker, and it changed everything. It changes our approach. It changes how we treat it. It changes what we follow. It's really a remarkable finding. And since then, there's been a number of other antigens that have been associated with it. Now, you know, this is all the secondary, but of the primary membranous, still only 2/3 of them are known to be PLA2 positive. And we talk about thrombospondin being the other one, but thrombospondin really doesn't represent that much either. There's exostocin 1 and 2, there's NEL1, and there's 2 others that I'll mention in a minute. But even when you look at all these antigens that we know, there's still a significant proportion of them that are unknown, or you could say 76% of PLA negative is still unknown. So now this doesn't include the other 2 which have been discovered since this table was made. But you know, I have a feeling that as we go through this, time passes, this list might be 20 or 20 different antigens. And I don't know what it is about proteins in the epithelial cell that are so antigenic, but it's really quite remarkable that this is happening. There must be something unique about the interaction physics or something of that cell that these antigens get exposed, and that then we start making antibodies against them. Because what other disease do we know that we have one area where all these different antigens and antibody complexes are being formed in situ, which is what we see with membranous. So now we have 2 more that have been reported by the Mayo Clinic. Semaphorin, which is seen predominantly in children, and podocalderin, which is also seen in adults. And again, like I predict there'll be many more of these as time goes on. We were hoping, that they were all going to be PLA2R positive, and that would call this primary membranous. But I don't think we're going to be able to call anything primary membranous anymore. And that's the point of this figure here, is that eventually we're going to be able to say this is membranous secondary to PLA2R, thrombospondin, NEL1, et cetera, and go from there. But it's going to take a while. And as far as circulating antibodies, it's been shown with PLA2R and the rest, but it hasn't been shown with thrombospondin, and it hasn't been shown with exostocin to have these circulating antibodies. So even, at least yet, so even with those, we're not going to have the great marker that we have for PLA2R positive membranous. But the real way that they're suggesting you do this is through mass spec, which is kind of what we do now. One of the recommended things to evaluate any amyloid is to not diagnose it biochemically, but to diagnose it by mass spec. And that may be the future too, that anybody with membranous will get mass spec and they'll tell you what the antigen antibody complex is, and you can go from there. Now we're targeting the PLA2R because we know it's an antibody, it circulates, and we give Rituxan or Cytoxan or to decrease the antibody. And that's what all the studies have been done. Most of these patients are PLA2R, but it may turn out that these are all just antibodies, and they may all respond similarly to Rituxan and shutting off the antibody. But time will certainly tell about that. Getting back again to this structure, I want to make one more point here, which is I think pretty interesting. Is that these are all intramembranous, and I don't know how to put it together with 2 months ago when he didn't have proteinuria, but this is the true classification that goes way back to 1968. Dr. Jeanette made these beautiful cartoons several years ago, but describing the 4 stages of membranous. And the first stage is when the deposits just go on top of the basement membrane, just subepithelial. And then eventually you see new basement membrane coming up, and these are the spikes. And then you get basement membrane completely encompassing all of the deposits. And that's what our patient would have, a pure stage 3. David described a couple of spikes. For the most part, this is a stage 3, which the idea here is this is all chronic. This doesn't happen overnight. So one of the criticisms about the CHIRG classification is that it often isn't pure. That sometimes you'll see spikes, and sometimes you'll see new deposits with old deposits and new deposits with holes. And so that's why it didn't catch on so much. But at least in our case, it really looks like he had an episode of membranous, no new deposits, and they're starting to resolve. And presumably at some point, if we biopsy him again, presumably, since he doesn't have any new deposits, he'll be stage 4, and he'll just have holes there. So the real question is to treat or to watch. And right now it's a moot point because, he's getting over his AKI. And we'll have to see how that goes. And perhaps when his AKI gets better, he'll excrete more a protein. He had 2.7 grams in the hospital, but that was a time when he was acute renal failure. And a lot of that wasn't even albumin. That was probably tubular proteinuria anyway. So it'll be real interesting to see when his when his creatinine level's off, where his nephrosis is. My inclination is to look at this and just to kind of sit on it a while and not automatically treat it, because I don't see any new deposits. But you know, I'm really extending my thoughts about, you know, based on pathology. But if he's severely nephrotic, it may be a whole nother issue, and we can go from there. One question came up about treating him with steroids in his infection, but we always get ID clearance before we do that, and we did get ID clearance. So, anybody have any other comments? I mean, I assume this guy had interstitial nephritis. It looks like it's allergic. He had a lot of eosinophils. I don't know what it's from. ATN as well, and this underlying crazy membranous, and we'll just have to see how he does with follow-up. I think he's going to do pretty well, though.
I guess the only thing I wanted to say is, again, I would still pursue, you know, the workup for other secondary causes before I just assume that this was PLA2R negative primary membranous. It's just my only thought, just as Bill had alluded to the fact that, you know, sarcoid can be coexisting with PLA2R, and whether the two are really connected or it's just whether it's just, you know, kind of serendipity is hard to know, but the same thing has been shown with malignancies in PLA2R positive. Now, this guy was negative, so it makes that issue even a bigger one, but it's just, that's my kind of final parting shot. I agree with you completely, though, that when the dust settles, if this guy turns out to be like he was before surgery with minimal proteinuria, I would have a hard time justifying treating him aggressively with any kind of immunosuppressive therapy, especially given his predisposition for ulcers and osteomyelitis.
Exactly. So Dr. Salzberg brought up a point, and you know, we thought about this. We are planning on getting malignancy workup, and that will be done. I don't know how you could possibly ignore it, but you know, the fact that there's no new deposits, I think they would argue it doesn't change what I would do, but I think it does maybe argue that there's that against a malignancy, because you'd think he'd be putting new deposits down, but you know, that's just, again, all this is supposition. So hopefully we'll get some follow-up. So wrapping it up, thanks everybody. Appreciate everybody's comments. The activity code is 4819292. Get your CME credit. I think this is, as Bill said earlier, this is why we do biopsies. Our number one diagnosis was ATN. Our second diagnosis was an IgA related, this is clinically beforehand, was an IgA related post-infectious. You know, we didn't really appreciate, I thought of all the pyuria was related to just the Foley and everything, but probably wasn't. And, you know, in retrospect, when you look at the proteinuria and the degree of tubular proteinuria, I think there was a clue there that there was this maybe a predominantly interstitial disease. But, you know, retrospectoscope is always 2020. So thanks, everybody. Stay safe, and hopefully we'll see you next week.